Good morning, everybody, and welcome to our latest webinar. I am Professor Paul Tipton from Tipton Training. I'm Clinical Director of Tipton Training Limited, also President of the British Academy of Restorative Dentistry, and I'm a specialist in prosthodontics. And today we're going to be bringing you a webinar on adhesive bridge design. And what we're going to be discussing is, first of all, general principles of bridge design. Specifically how that works for adhesive bridge work as well, but you need to understand some of the basics of bridge design in any case. We're going to look at longevity, how long they last, how predictable they are. Look at the resistance and retention form that's required, and by that I'm talking about do we need to do tooth preparation, how much tooth preparation do we need to do. We'll look at cementation. Cementation is pretty straightforward for metal-based, but a little bit more complex for zirconia-based adhesive bridge work. And then finally, we'll look at the adhesive bridge work against zirconia with a view to looking at the aesthetics and what we can achieve aesthetically. So let's start off with bridge design. I'm going to take you back right to the very beginning, okay? This would fit in very nicely with those of you that have viewed my webinar on bridge design. I've done a couple of webinars, part one, part two, about 2 hours in each on how you design bridge work. So this would fall in very nicely, and I can't obviously spend that much time on all the aspects of bridge design. So it'd be very, very good if you could get to watch that. I've also done a series of about 15 papers on bridge design, which is readily available on the internet for those of you that want to learn a little bit more. So we go back to 1926, and Anti put forward his Anti's law, if you like, that the root surface area of the pontics should be equal to or should not exceed the root surface area of the abutment teeth. And in the 1970s, that was fine up to 1970s. 1970s, work done by Linda and Nyman, two periodontists over in Sweden. They did long span bridge work, the periodontal prosthesis. I'm doing a webinar on the periodontal prosthesis in a few weeks' time, which you might want to catch. The periodontal prosthesis is one whereby 12-unit bridges were put on two canines or two mobile canines. Multiple pontics were loaded onto very few remaining teeth. And this went well against Anti's law. So Anti's law, I won't say disproven, but we've got around Anti's law. We know a lot more about it. And the only time that we use Anti's law today is for cantilevers. And that's a very, very important part, because when we look at adhesive bridge work works best, you're probably aware of this, in a cantilever situation. So in various studies, and we can name studies that go back a long time, more recent studies, the cantilever is a very, very successful type of bridge. Statistically, the cantilever bridge and the canine to canine 6-unit fixed bridge, they're more or less the same in terms of longevity, both around about the 15-year mark. And we have to understand why, and specifically when we're talking about the adhesive bridge. Now remember, an adhesive bridge is nothing different to a normal bridge. All we're talking about, and what I'd like you to try to understand today, is a bridge is a bridge. We design a bridge. And once we've designed the bridge, we then will choose our retainers. An adhesive metal wing or zirconia wing is a retainer. That's all it is. So when we start to talk to patients about, well, we can do a partial denture for you, we can do an implant for you, we can do a conventional bridge, or we can do an adhesive bridge. If you think about it, that's a bit strange. You wouldn't dream of saying we can do a partial denture, an implant, a conventional bridge, and a gold inlay bridge. You wouldn't say that, would you? But you say this for an adhesive bridge as though it is something completely different. No, this is a bridge. We know what bridges do. We know how to design bridges. Okay, and just to recap, we design bridges always from the front to the back. So you'll see patients with multiple gaps. Always design the front space first of all, and then go to the back. Second, number two, we go and choose our abutment teeth. And we've got to have good abutment teeth. And ideally abutment teeth that have good quality bone, that have got lots of tooth tissue available to us and are vital. Those that aren't, we are now dealing with unpredictable results. And there's many the time that we will say, I'd rather take an abutment out and make the bridge longer and work on good, healthy abutments in terms of trying to get longevity. Okay. Number three is choose your design. And in terms of design, we've got several designs we can choose from. We've already mentioned cantilever. We have the fixed movable design, which I'm going to talk about. We have the fixed design. Okay. Those are our standard designs. On top of that, we've got some of the more exotic designs, the coping bridges, the hybrid bridges, the Lindner and Nyman periodontal prosthesis, etc. Number four, and the very last, choose your retainers. And the retainer can be full crown, 7/8 crown, 3/4 crown, onlay, inlay, post crown, adhesive wing. We've got that full choice. So please, when somebody comes in and is missing a tooth and you're talking about bridge design, think about bridge design from front to back. And the very last part of it is, what is my retainer going to be? And we tend to make those judgments of all of the different types of restoration. Again, we'll make the same judgment when we're deciding with a broken MOD on the upper right 6, palatal cusp fractured. What are we going to do with it? Are we going to put a crown on it? Are we going to put an onlay on it? Are we going to do a big composite? Are we going to do gold, zirconia, PFM? You've got many, many variables. What we need to be discussing with our patient and in our own mind thinking about is three things, three aspects. When we're designing a bridge and we're looking at the bridge and we're deciding what type of bridge we're going to do for somebody, really important you think about three criteria, the three main criteria for success in restorative dentistry. And you know, I talk about this word predictable all the time, and this is again predictability. If you understand bridge design and you design the correct way, as we've mentioned, from front to back, etc., abutments, design, and then retainers, you will get predictable end results. We can only work on predictability. Your practice will thrive. You will gain confidence. You'll be able to do more and more private high-end work if you attain predictability. So predictability comes from discussing with your patient three criteria, okay? And most patients want all those three criteria. The three criteria are longevity, okay? We need to choose restorations which are going to last the longest amount of time. No patients like to come back to us time and time again. The second thing that most patients want is aesthetics. Not everybody, but that is a very big criteria. The third criteria, more and more nowadays, as we're living in a world of minimally invasive dentistry, is minimal tooth preparation. Maximum longevity, maximum aesthetics, minimum tooth preparation. Now, what do we know about all of our restorations that we do for patients? We cannot get all three. I cannot do any restoration that is going to give the patient the maximum longevity, the maximum aesthetic impact with the minimum preparation. So we have to choose 2 out of 3. And this is where, again, the adhesive bridge comes in. It may not be the most aesthetic. It may not last the longest amount of time. But as a bridge retainer, it is one of the least invasive types of preparation. So setting the scene, we have in front of us a 3-unit bridge with Maryland retainers. Now, generally the problem with Maryland retainers, and we get it down to the very basics, is they lack resistance retention form. If a retainer lacks resistance retention form, then when it is under function, the cement has a greater chance of fracturing. If the cement fractures, whether it is a post crown, whether it's a standard crown, whether it's a Maryland wing, then the bridge comes off. If the bridge has got 2 retainers and only 1 retainer cement loop fractures, the bridge doesn't come off, and this is where we have problems. Caries, decay now gets underneath, and we have various problems with that. So in order to stop that, we need to look at ways of taking the stress away from the cement lute. The unpredictability you will see from Maryland longevity studies tends to come from unpredictability of cementation failure. You know, with a crown, you've done a lot of crowns probably in your life. Not many crowns, when they're prepared properly, ever come off. Very, very few. Why? You're using cement, of course you are, but you've got great resistance retention form. So we have this balance, if you like. More tooth preparation, better longevity, better resistance retention form. However, less in terms of the minimally invasive dentistry. So we look at a situation like this and we say to ourselves, where is the resistance form? Where is the retention? Now, retention is a function, as you're all aware, of surface area and glue, the cement glue. Resistance form is a function of the bridge being displaced by pushing, not by pulling. So in a case like this, we've got no resistance form whatsoever. When we have no resistance form, what does that mean? It means we're asking the cement to act not just in terms of retention, but we're asking the cement to take the function of resistance as well. And guess what happens? It can't, and therefore cement lutes fracture. Hence the unpredictably in Maryland adhesive bridges, and that's because dentists do not usually understand resistance and retention form as well as they should. So let's look at this bridge. Now, we know that this bridge has failed, and I'm looking at it here, and the metal work has been broken here. It's come on and off several times. We know that if a bridge comes off once, there is a good chance that the metal wings have distorted. So the chance of it surviving a second time when it's cemented are less and less and less, roughly 50% of the time. Okay, so if a bridge has been on for 6 months and it's come off, it's more likely now, unless it was poorly cemented, that it will be 3 to 4 months when it comes off again. So this bridge has been off many times. Let's go and describe now why it's come off and what we could do to make this work. So it's come off because the cement lute has been overloaded. Okay, why and how? Well, let's just look at this patient. You can see on the metal looks as though it's got some little wear facets, etc. on it. Let's just say that this patient is a bruxist. Okay, remember 25–30% of your patients will be bruxing tonight. Everybody will probably brux at some stage. So worst case scenario, our patient is a bruxist. You have to plan every single patient you see as if they are bruxist. Otherwise, this can come and bite you. And if somebody bruxes and you didn't think they were, and you did not take steps to stop it, then you're going to get failures. And again, what happens then? Reduction in predictability. And we know what that means. So at night time, my patient's lower incisor is going to go for a walk up and down that metal. Okay, I'm going to grind forwards and backwards like this. Okay, now what happens? My lower tooth initially is sliding on the back of metal. What happens, and remember then that my cement is under compressive load. As I'm grinding on the metal, the cement is under compressive load, which is what we want it to be. Now, what happens when we go from metal to tooth? So I have my lower central incisor grinding, and suddenly I'm pushing onto the metal wing. Suddenly I go bang onto incisal edge. Bang onto incisal edge. What happens? When the lower tooth meets the upper incisal edge here, enamel, okay, that bridge is now under tensile stress. And we know tensile stress will fracture cement lutes. Compressive load very seldom fractures cement lutes. So we're now under tensile. And that change from compressive to tensile has happened like that. Okay? And every single time we go up and down, we go from metal to tooth. We go bump onto tooth, bump onto tooth, bump onto tooth. So we now add in tensile stress, but we also add in repetitive strain injury. Bang, 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 bang. And what happens? The cement breaks down. Why? Because there is no resistance form, which is stopping that tooth moving forwards. Now, exactly the same thing's going to happen here. If we go into a lateral excursion and we happen to have lateral stress on that lateral incisor, the same thing will happen. But because we have now joined both of those teeth together, okay, in a fixed bridge, remember Maryland's not good in a fixed situation. Okay, Maryland's work best in a single cantilever. So in a fixed situation, what have we done? One of the biggest stress breakers we have, okay, remember stress breaker, that means taking stress away from cement lute. We have to always try and encourage in our bridge work a stress breaker. Stress breakers take stress away from cement lute, from ceramic, porcelain, from the tooth itself, stops the tooth fracturing off. So we need stress breakers. Our stress breakers can come in three forms. Number one, it can be the periodontal ligament. I'm going to talk about that here. Number two, it can be a mechanical stress breaker, which I'll talk about a little bit later. Number three, we can sometimes use a soft cement, as in a coping bridge. So here, because we've got two teeth, central incisor wants to move this way, lateral incisor wants to move that way, okay? And therefore, central incisor cannot move this way because that lateral doesn't want to move that way. It wants to move that way, okay? So now the central incisors periodontal ligament is more or less useless in terms of mobility and stress breaker. The periodontal ligament is our stress breaker because it has mobility. So we are now getting a situation where we come forwards and backwards, and it's as though we've got an ankylosed tooth here. Because it's a fixed bridge, the stress is going directly to the cement lute. We have no resistance form, the cement lute fractures. Simple as that. So how can we get around this situation? We can get around this situation very easily. Number one, by changing bridge design. And I mentioned it once, I mentioned it many times, I'll mention it again and again and again. Single cantilever, ideal for the front of the mouth. Now what happens? We can still keep the metal framework 2 millimeters below the incisal edge. That's fine. But as we go from metal onto tooth, and we have that bang onto tooth, but our tooth has got a periodontal ligament. So as we go bang onto tooth, we go boing, 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 and the periodontal ligament takes that stress. It is a stress breaker. And hence, even though we still have tensile stress on the cement, because of the movement in the periodontal ligament, that stress is dissipated and it's much more reduced. Okay, that's option number one. Okay, what's option number two? Option number two would be somehow, okay, make sure that we could never ever have that lower tooth grinding on the upper enamel. Okay, so all that could happen is either the lower tooth went forwards and backwards on metal, or the lower tooth didn't go forwards and backwards on the tooth at all. Okay, so this is either number one, bring the metal framework right up to the incisal edge. So the metal will always be under compressive and never under tensile. So we could do a fixed bridge here if we wanted to. Okay, and I'll show you a preparation later. We could do fixed, but we take the metal right up to the incisal edge. Now there's no tensile, it's under compressive, and the cement will not fail. Okay, and you do this an awful lot at the Eastman. You know, at the Eastman, they do a lot of Maryland bridges. What's the problem here? We've got longevity, we've got minimal tooth preparation, but guess what? Aesthetics, you can see the metal at the incisal edge. Put your head back like this, you can see metal on the incisal edge. So really good looking, really good results, but poor looking. Okay, what else can we do to make sure that that lower tooth no longer hit the upper incisal edge? You could maybe look at the occlusion, and you could maybe go and say, okay, well, can I put some guidance maybe onto that lateral incisor or onto these two canines? So in protrusion, okay, the lower incisors never touch the upper incisors, or at least the lower incisors never touch the upper incisal enamel. Again, that way would be taking tensile stress away. Okay. Third way would be accept tensile stress, but put much more resistance retention form in. Okay, and I'm talking mostly about resistance form. Okay, if your tooth wants to move outwards like this, what can I do in terms of resistance form? Simple. We put a mesial groove and a distal groove in place. With a mesial and distal groove, we now cement the bridge so it goes from the incisal edge. I'm not cementing from the palatal. I have to cement down the incisal edge of my tooth preparation. So there's my tooth. I'm not going to cement my bridge work on from palatal like this. I have to design it so I cement it from the incisal edge. The metal goes into those grooves. It cannot now, the tooth cannot physically move out of the metal. You've created resistance form. And that's what we will do when we look at tooth preparation features. And, okay, so we've done this with a simple Maryland now as a cantilever. It works very well. The periodontal ligament's taking the strain. So everything's good in the world. What else do we know about generally adhesive bridge work and normal bridge work? This is not just adhesive. This is also traditional bridge work. Success rates of all bridges will increase with a decrease in the number of abutments. Think about this now. Think about the percentage of bridges that fail due to, and the four major factors are caries, endodontic problems, cementation failure, and poor fitting margins. Those are the major four reasons, okay? Versus potential, if you don't have enough abutments, occlusal overload. Those four first reasons count for about 75% of all bridge failures, okay? And the amount of bridges that fail due to occlusal overload, they generally become more and more mobile and now have to come out, is between 4 to 6%. Let's just call it 5. So you got 75%, those four main reasons, 5% because of occlusal overload. Okay, what do you do when you add more abutments into a bridge? You increase the risk of caries by 4. You increase the risk of cementation failure. You increase the risk of endo. Every single time you do a tooth prep, to put an extra abutment into the bridge because you're worried about overload. Every time you do a tooth prep, then you've got, depending on the studies, 15, 20% chance of an endo, okay? And again, margins, you have more margins for failure, and it's more difficult to do bridge work with more margins in place, more margin failure. So increasing the number of abutments creates increased failure. Decrease abutments, decrease the number of failures. And this has been known for a long period of time. Splintered retainers give an increased risk of failure. And look at a couple here. These are a couple of failed adhesive bridges, okay? And the dentist has gone for a bridge replacing 2 lower central incisors, but he's used the lateral and the canine as abutments both sides. And what can we see here? The Maryland has come off and we've got caries underneath. We've got staining, we've got caries underneath. And this is because we do not want to splint teeth together. Splinted retainers give an increased risk of failure. Why? The more retainers, the more chance of failure, the less you've got your periodontal ligament stress breaker in play. Again, another very, very poor design where we've got abutments and we've got a second splinted abutment. We've got an abutment here as a full crown retainer next to an abutment with a Maryland wing. Same thing there. This is going to fail. It's going to fail because we've got really good resistance retention form here, minimal resistance retention form there. And when this bridge came off, we had a massive caries underneath because when the bridge was fitted, it probably stayed cemented to those premolars with the Marylands for probably a day, couple of days, a week. After that, cementation failure because no resistance retention form, massive caries underneath. So let's just show you a case where we've changed multiple retainers for single retainer. So we have a lady comes to us with a missing lateral incisor or a gap where the lateral incisor should be. This is the bridge design. And again, one says to oneself, why on earth are we having 3 retainers for one missing tooth. Too many retainers, too many chances of failure, okay? And our lady comes to us saying, this bridge comes off about once every 2 years, but before that, it becomes a bit mobile. I've had the bridge on for 10 years. It's been off many times, and the bridge design is incorrect. Why is it incorrect? Because we've taken the periodontal ligament out of the equation. So we take the bridge off and we look to try to improve the aesthetics. First of all, by improving aesthetics, we need to make sure that we're going to have cutback. This is a case I did before zirconia, so we could be using zirconia for a case like this. We didn't, because this was about 10 years old, this particular case. We look at the soft tissue, and we need to do a little bit to that soft tissue. So we're going to do some gingival rotary curettage. We'll take a nice big round burr, and we're going to drill up into the tissue and create a concavity, so I can get a better looking ovate pontic to come out. So here's the original. This is what we're doing, and this is what we create. Something that's got a nice gingival margin at the same level. We go back a couple. What I'm trying to produce here is a gingival margin at the same level with some concavity. So it appears that my pontic is coming out of the soft tissue. And there we are with our final pontic shape. We're now going to go and take an impression. Before we do that, we do a little bit of tooth preparation on the lateral incisor. So we put rest seats on. Here's a rest seat. There's another rest seat. I put a little pin channel down into there as well. You can see the pin, and you can see there's a mesial groove there, and there's a small distal groove in there, just there. So we put two grooves. We put rest seats in. We put a little pin channel, and there's my Maryland. Okay, we've got good resistance form. We've got good retention. We can take the metal 2 to 3 millimeters away from the incisal edge, so we don't get any graying. And we've got the periodontal ligament that will now take the strain. So this is another lateral incisor, because remember the tooth that we're missing here is actually, it's not a lateral incisor missing, it's just a gap that's opened up. I think it was a supernumerary that was probably there in the first place, and it's now never been replaced. So we've got an extra lateral incisor in place, and a reasonably good aesthetic end result. So those are some aspects of bridge design. I'll say it again, just to recap. We need to, because the Maryland does not have the same resistance and retention form as a full crown. It is therefore liable to have more stress on the cement lute. We therefore have to do one of two things: either introduce more resistance retention form, we'll talk about that in tooth preparation, or go to a bridge design where there is more stress breaking. So we don't have the stress on the cement lute. And that means cantilever or fixed movable design, not fixed. If you're going to do a fixed Maryland, we have to put in plenty of resistance retention form, which is tooth preparation. Let's look at longevity now. We've got various studies. So let's look at the study by Priest, first of all. So this study, 25 years old, Priest was looking at a meta-analysis of all the designs of Maryland bridges. I mean, remember, Maryland bridges are not new. They have been out. We have been doing Maryland bridges since the late 1970s, early 1980s. Okay, so they've been in use now for over 40 years. We know what works and what doesn't work. Okay, and that's hence the reason for this webinar. So in 1996, 25 years ago, people did not understand, dentists did not understand correctly how to do these bridges. And were just, because remember the original protocol that came out was take an impression of the palatal aspects, stick a metal wing on. No tooth preparation, no real idea how big the wings should be, okay? And it was just take an impression, stick 2 wings on. Everything will be okay. And like with all new techniques, they have to go through multiple stages where they fail before we then adopt or adapt our technique for success. So we look at are success rates. Success rates vary from 90% over 11 years, okay, which is what we want. That's what we're aiming for. All the bridge work that you do, you should be looking and saying, I want at least 15 years on average from my bridge. Otherwise, it's going to be experimental. It may be then a long-term provisional or prototype. But I want 15 years minimum. Ideally, I want 20, 25, 30 years out of my bridge, which incidentally is often a lot longer than it would be for a single tooth implant, but that's another story. So they range from really good success rates to really poor success rates. Look at this, a 46% success rate over 11 months. And those are some of the studies whereby dentists have not understood how to do these bridges. More recently, Peterson did a very nice study where he documented success rates of Maryland's adhesive bridge work versus conventional versus single tooth implants. And he found 88%, as we can see here, with Maryland's. He found that 5-year success rate for conventional was in the region of 92%, and the 5-year success rate for implants, 95%. So statistically, there's not a lot of difference between them, but that is if you do the correct design, okay, and put in some tooth preparation when required. What else do we know? We know that maxillaries last longer than mandibulars. We know that anteriors last longer than posteriors. Okay, so why is that? Maxillaries, okay, most of the cement usually under compressive. Mandibulars, stress is usually from the word go, tensile. Hence, when we come to look at tooth preparation, we'll nearly always do more tooth preparation for a lower, less tooth preparation for an upper, because the lower is going to be under tensile stress. Whenever we tap up and down, whenever we go into protrusive or lateral movement, the bridge work will be under tensile stress. Upper will be under compressive. Anterior versus posterior, we know that anterior there's less biting force, posterior there's a greater biting force. If there's a greater biting force, then there's a greater likelihood that the cement will get overstressed. So let's look at tooth preparation techniques now and what we can do. So remember, our tooth preparation technique is designed to take the stress away from the cement lute. We're looking to have resistance form and retention form. We taught this at university, okay? Everybody's taught this at some stage. Any form of indirect restoration, we need resistance and retention. And there is a merging between the two. Okay, retention form is that type of tooth preparation which stops the bridge being pulled off the same way as it was cemented in the first place. Resistance form, those types of tooth preparation that stops the bridge from being displaced under non-axial loading. Okay, we need both. Retention is mostly a function of surface area. Resistance form is a function of guide planes, making sure you maximize your surface area, axial inclinations and convergence angle, rest seats and grooves. And those are the things that we need to put into a bridge. So the original concept that adhesive bridge work, resin retained bridges were reversible has now gone out the window. Okay, in some instances they can be reversible. In some instances, let's say a lateral incisor being replaced from a canine. Canine got a lot of surface area. You're taking the metal wing right up to the tip of the canine. You don't need any resistance form, but you need resistance form in certain situations. And the type of preparation we're doing, as we mentioned, is as much wraparound as possible. We're going to wrap around maximally, but into areas where it cannot be seen. So as we go further backwards in the mouth, we can do more wraparound because you see less. When you smile, you see less of the tooth. Okay, most people, when they smile, they only see the mesial buccal, maybe the upper 6. Therefore, we can have wrap around the mesial aspect, the platal aspect, the distal aspect, all the way around very often into the mid-buccal groove. The further the wrap around, the greater the resistance form will be, even to the extent that when you get to a molar tooth at the back of the mouth, when the patient smiles, big wide smile goes ee like this. If you cannot see the mesial buccal, then it's advisable to do a 360-degree Maryland. And that's a little bit like a ring which is placed on the finger, and it's bonded 360 degrees. We have far more mechanical strength and far better resistance form if we can go 360 degrees rather than 180 or 270. It's a little bit like a 3/4 crown preparation. For those of you that understand Go 3/4 crown, 7/8, it's that same style of preparation. Grooves, we put grooves in. They're called full grooves, but they're mini grooves. And remember, all of these preparations, we do not dare go into denting. So all of these preparations are intra-enamel. Maximum depth is 0.5 of a millimeter. Okay, so everything is still in enamel. So theoretically, if the bridge came off, there would be no dentine exposed. Not reversible completely, because there's be some strange shapes on the tooth, but no dentine exposed. And again, restorations placed on tooth preparations, having, as we've mentioned, have got better success rates, better longevity. Our studies show us that. So let's start talking about what these things look like. And I'm showing you now a canine with the maximum. I'm not saying, please, time out. I'm not saying you do this preparation on every single canine. No. What I'm saying is that these are the maximum number of individual preparation styles that you can do. So let's talk about them. What can we do? We can put rest seats in place. And in this instance, I put one rest seat, second rest seat, third rest seat. What does a rest seat do? We have an inclined plane. By putting a rest seat in, it now does two things. It gives you resistance form to apical displacement. The second thing is it gives you a vertical wall. That vertical wall is going to give you, again, further resistance form. So I've got rest seats here, which will stop apical displacement, but also I've now got a vertical wall next to it. And that vertical wall just here, will give me added resistance form. What else have I got? I've got a mesial groove and I've got a distal groove. And the mesial and distal groove are going to stop lingual displacement. I put a third groove in, okay? This is a bit going over the top, but this is there for long span bridge work only when you need to have more strength, more rigidity in that mid-lingual or palatal surface. And I have a finish line. So all of these preparations, maximum 0.5 millimeter deep, my finish line 0.3. We look at Maryland wings, minimal preparation or minimal thickness, sorry, for a Maryland wing, 0.7. Yes, we can do them 0.3 millimeters in thickness, but they tend to bend more. Okay, and what we need to do, we know from bridge design studies generally, the more rigid the bridge, the less it bends, the less stress on the cement lute. And therefore, when you go for bigger spans, you need to have a more rigid framework, and that framework also means the metal wing needs to be more rigid. So I like to have a 0.7 millimeter metal wing to reduce rigidity. Now, we're going to now look at doing what is going to be a difficult case, which is going to be a canine to canine fixed bridge. Okay, why are we going to do it? Well, we've discussed with our patient that our patient wants bridge work rather than implants, doesn't want a partial denture, and would rather have less preparation than more preparation, and is not that bothered about the aesthetics. By that, if the canines go a little bit gray at the tip, not that bothered. So it's now going to be a fixed bridge. Okay, remember, fixed bridges put more stress on the cement lute, therefore we need more resistance retention form. Now let's just look with when you design any Maryland bridge, please think about displacement. Okay, remember, resistance form is there for displacement. Resistance form takes stress off cement lute. Cement lute only, what I want is retention from it to stop the toffee chew coming up. Okay, so let's just imagine now we're going to put a bridge into here, a K9 to K9 bridge, 4 pontics. Where can it displace to? Okay, so first thing, we bite up and down on the pontics. The pontics need to have contact. As we bite up and down on the pontic, what happens? The bridge wants to move apically. How do we stop that? We take that inclined lingual plane, and as we've mentioned, we now cut a rest seat in. Let's just go back. Okay, we cut a rest seat. That can be 1 rest seat. It could be 2. It could even be 3. More rest seats, more resistance form. What does a rest seat do? It means the metal, when it goes into there, I've now got a 90-degree, okay, bit of metal sticking into the tooth. Okay, now you tell me how that bridge can displace apically when I've got a 90-degree angle with metal fitting in there. It is now physically impossible, as long as the metal fits well precisely into the rest seat. It's a physical impossibility for that bridge to displace apically. The only way it could displace apically would be 2 ways. Number 1, for whatever reason, the bridge is distorted. Number 2, the underlying part, okay, underneath the rest seat, this part of the tooth or that part of the tooth has fractured away. So I've created now resistance form, which means the bridge cannot displace apically. Okay, what other way could it displace? Okay, it can displace lingually. Why? If I go into a protrusive movement. As I'm doing that, my lower incisors are being pushed lingually. How can I stop lingual displacement? We've mentioned just earlier, grooves. So we put a mesial groove in, we put a distal groove. And remember, this bridge, it will be fitted from the incisal edge downwards. It's not going to be fitted from the lingual, it's going to be fitted from the incisal edge downwards. Now, if we put a groove in the mesial and distal there, how on earth can the bridge displace lingually? The only way it can displace lingually is if either the metal wing distorts, okay, and it bends under loading and comes out of that wing, or number 2, the enamel itself breaks and fractures away. So I've now looked. Any other ways? Any other ways this bridge can displace? No. So I've now looked at the 2 ways. And please use this when you're doing every Maryland you do. Okay. Number 1, figure out where can my bridge displace. Okay, Mr. Patient, tap up and down, grind from side to side, forwards and backwards. How can my bridge displace? Okay, write down, it can displace this way, this way, this way, and now work out what the resistance form needs to be to stop the displacement. Now you're only relying on the cement loop for retention, which is what you want. Okay, so let's move on and go with the lower K9 to K9 bridge. First of all, understand, this is one of the longest lasting bridges you can ever do for somebody. Okay, whether it's going to be a conventional bridge, whether it's going to be a Maryland. This is one of the best bridges that you can do. Why? Well, many reasons. First of all, K9, big tooth, lots of potential resistance retention form there. What else? K9, longest lasting teeth in the mouth. Lower canines, longest lasting teeth, followed by lower first premolars, followed by lower second premolars, followed by upper canines. So, great. Tooth with the most proprioception. So lots and lots of reasons why these sorts of bridges last the longest amount of time. But they're not going to be easy to prepare. To prepare where you've got a big gap between teeth is not as easy as where there's a small gap. Small gap to prepare between teeth, 3-unit bridge. You can see one tooth, you can see the other tooth, okay, in the same line of vision. Big space between the two. I now have to tilt my head to look at that one, tilt my head to look at that one. I can't see them in the same frame, especially so when we use our 5-6 times magnification loops. So it becomes a lot more difficult. So tooth preparation techniques need to be spot on. You need to understand how to lock your wrist during preparations. You need to understand speed increasing hand pieces and how we prepare those or how we use those. And also we can go to paralleloprep. And this is a very, very useful piece of kit. Remember, if you're doing a lower 3-to-3 canine to canine bridge, Maryland, that's an expensive bridge. That bridge should last, again, 15 years plus. It behoves you to go and do it properly, okay? And if you're going to do it properly, you spend time on it. You put all the resistance retention features in, okay? And in order to do that properly, either be good at tooth preparation and learn the techniques, or go to some gadgetry. And here we have some gadgetry. This is the Paralleloprep. And it's a little piece of machinery, piece of equipment, which you can put onto one side and now prepare all the teeth parallel to each other. So it's really useful where you want maximum resistance retention form for minimum tooth preparation. So our starting point, I'm going to walk you through now some of the tooth preparation features of the canine to canine bridge and how we actually do them. So we tend to start off with a super gingival 0.3mm chamfer. We'll finish off with a chamfer, and that's usually 1 millimeter to 0.5 millimeter super gingival. And that's going to go from the mesial region, lingually, and just above. We have two options as we go through distally. We can actually go through, or we can go above the contact point, okay? Straight away, you see that if you're going to take your burr into this area, you're now in an undercut area. So this is where guide planes also have to come in place. We have to make sure that we've got good guide planes, which means we have to take the convexity of the mesial surface away. We need to have a flat mesial surface that's inclined 6 degrees. So we can have the right axial inclination. These are not easy tooth preparations. So I'm now preparing my mesial slice, getting down to my finish line with a 6-degree inclination and providing a very, very long wall for bonding. Okay, my Maryland is going to bond all the way around here. We're now going to produce our groove. And our groove is going to be done with a tungsten carbide burr. Most of the preparation with tungsten carbides, because tungsten carbides cut precisely. They will cut a very, very sharp feature compared to diamonds, which tend to abrade more and will give a more rounded preparation. So I like to use tungsten carbides for these 3/4 crown preps, gold work, etc. And for Maryland's, tungsten carbide wherever possible. So we're now going to produce that mesial groove. And the mesial groove is going to go down in terms of its angulation. Remember, we're fitting this from the incisal, so it needs to be going down the long axis of the tooth. There's no way your mesial groove can go at that angle. So we have to think about the long axis of the tooth. I'm cementing it from the incisal down the long axis, so my groove goes down the long axis. And we cut into the tooth. Okay, and here is my mesial groove, cut into the tooth. I'm now going to decide again about the distal, and I've got two options there. I go above it or I go through it. If I go through it, it means more tooth destruction, yes, but we get more resistance retention form. Only you can tell, okay? Only you can tell the patient how much tooth destruction we're going to do versus longevity. So in this instance, I'm just showing the next preparation. I will go through the contacts. I'm showing you two preparations, an anterior and a posterior. In this instance, I'm now going to go above the contact point. So I go again with my groove parallel. My burr's got to be parallel. So two-handed tooth preparation, locking your wrist, doing one groove up over the top and doing the other groove, okay? Or using the Paralleloprep. Do not try to parallel grooves together looking in a mirror. Doesn't work, okay? Only way you can parallel grooves together is locking your wrist, doing one, then up over the incisal edge to the other, and then pushing in, doing the other, okay? and we're putting our distal groove now in place. Next thing I'm going to put, because this is going to be a long span, I'm going to put an extra groove in the middle of the tooth, and that middle of the tooth will give me added rigidity. Don't need it for short spans. Longer span, I want that added rigidity there. So my Maryland wing will not bend under large amounts of loading. And again, it's going to be finishing well below the incisal edge. It's more or less in the middle, just above my finish line. Next stage after that is I'm going to start preparing my rest seats. And that could be 1, 2, 3. The more you put in, the more resistance form. With a canine, you've got a big lingual surface, you can put up to 3 in. With maybe a central incisor or lateral incisor, maybe you don't have the same amount of tooth surface area available, and so it's only 1 or 2 rest seats. You see what we're doing here. I'm mapping them out first of all, and this is what I'd suggest to you. We do a full day on our Phantom Head course on Maryland bridge design, and what we find is the first time that our students do it, we have to throw it away. Second time, throw it away, and on about the 4th time they get it. And the difficulty is, number 1, learning the tooth preps, and then minimizing the tooth preps. So the first thing you need to do is learn where they should go, what they should look like, how you do it. And then after that, we need to minimize, use smaller burrs to do it. And one of the ways to make sure that you're doing it slowly, bit by bit, is initially to map out where your rest seats are going with a speed increasing handpiece, and instead of a tungsten carbide, just a normal diamond tapered burr with a nice either shoulder or chamfer finish. And what that does is it just puts little lines onto the lingual aspect. Once you've got those lines, okay, and here I'm just mapping out the lines, okay. Once you've got those lines, you can change for a tungsten carbide and now make that sort of very thin, small little feature into a nice sharp 90-degree angle. But again, all of these are done with the speed increasing, where you've got more control. So we draw and map it out, and then we go around with a tungsten carbide. So here's my initial drawing out, and then with the tungsten carbide to make it sharp. Okay, and what we're doing here with our 3 rest seats, we're going to change or connect the groove. So distal groove connects up to mesial groove, top of distal groove connects up to top of distal groove, and then I map out where my metal finish line is going to be for the technician. So here's my rest seat, my first rest seat completed, and we don't go straight across. We go down towards the gingival margin. We follow the same sort of contours as the lingual soft tissue, go down and then back up. Next one, we're going to go straight across. We'll have still a little bit of curvature to it, but we're going to go from top of groove down a little bit to top of groove. So I have 2 rest seats that link the bottoms and the tops. And this is really important. In terms of casting, this is going to be non-precious metal. In terms of casting, we get better casting if we have flow. And that means that grooves can flow, one groove can flow through the rest seat to the other groove. We got much better casting, a more accurate casting, less chance of porosities. Okay, and again, here I am now just going from top of groove to top of groove, producing my 90-degree rest seat, 0.5 millimeter deep, that's all. And at the same time, it's cutting a vertical wall here. And that vertical wall, and that vertical wall, and that vertical wall, and that vertical wall, and your slice prep all goes towards giving you now increased surface area and the correct axial inclinations. Speed increasing, smoothing it down. Okay, and again, second rest seat completed. Now I'm just going to go and do the third one exactly the same way. And this is now approximately 1 millimeter from the incisal edge. You can choose how far it needs to be from the incisal edge. Could be 1, 2, 3 millimeters. Okay, in this instance, we're keeping 1 millimeter from the incisal edge. There's my third rest seat. And there's the completed preparation. Takes a bit of getting used to. Okay, non-reversible, but nothing indenting. And of course, we have to go, and in this instance, we're not just dealing with one canine, we're dealing with two canines. So when you're doing with bridge work across the midline, as we've said here, most important part is always bring your burr to the midline. Bring your burr to the midline, angle it so your burr is in the correct plane, both facially and mesiodistally. So the burr needs to be in the correct plane. The plane mesiodistally is the long axis of the face, the center line. The plane labial-lingually is the long axis of these teeth. Okay. Once you've got your plane in the center, we're just orientating my burr in the center, then we lock our wrist and we prepare one side and the other side. Then we lock our wrist and prepare distal and distal. We always go one feature on one tooth, same feature on the other tooth. So for midline, we go one side, then the other side. Then we'll do another feature. Let's just say I'm going to do the first rest seat. Okay, I come back and orientate myself down the middle, the long axis of the tooth and the center line, orientate my burr, then lock my wrist and go and do a lingual prep and a lingual prep. And that way you get all your preparations parallel to each other. And then we can take a nice impression. Okay, so those are our tooth preparation features. Okay, I'm just going to show you another example now. Little old lady, 87, 88 years of age, has had a fair bit of bridge work and crown work done, as you can see. Not the fanciest, looking quite old now, but doesn't need a lot of, doesn't want a lot of invasive work. Has lost a lower central incisor. Okay, knocked it out. Playing with the cat knocked it out. And now we're going to do just a single cantilever. Remember, single cantilevers, we don't need as much resistance retention form because we've got the periodontal ligament. Fixed bridge work, we need more resistance retention form because we don't have the periodontal ligament or stress breaker in play. So now I'm going to do a little bit of preparation on this lingual aspect. What am I going to do? I'm going to put a mesial groove in here. I'm going to go and put in a distal groove in there. And when we put in distal, remember, we go into the tooth and out. We don't go into the tooth and out lingually. We have to go in and out. If we go in and then out lingually, we don't have a groove. Okay? We don't have a groove. We have a wing. So again, we go into the mesial and then we come back out again. That means that your groove has a buccal wall and a lingual wall. Okay? It's important. That lingual wall stops the displacement. I'm going to go and put a finish line in place, supragingival, and I'm now going to put 1 and 2 rest seats across. You'll see a little bit better here on the silver die. One groove, another groove, rest seat, rest seat. And again, now my technician will start to make the non-precious metal. We're taking it right up to the incisal edge as close to as possible. This is not a case with this little old lady where she needs maximum aesthetics. Not the previous case, younger lady, upper lateral incisor where we had to cut right back. This is going really close to the incisal edge now. Aesthetics, not a problem. I want longevity for her. I don't really want her to ever have to come back and have anything done again. We also put a little lug just over the top to help seating. But one of the advantages that you're going to have with tooth preparation is you're going to get great seating, which means that when you come to put your rubber dam on and cement it in place, it fits or it doesn't. Okay? It's not like trying to get something which slides down an inclined plane. You're never sure if it fits in the right position or not. This is a fit or it's not. And on the metal now you can see sandblasted. We'll talk about sandblasting a little bit later on. We've got mesial wing, we've got distal wing, and I've got my little rest seats, one rest seat there, another rest seat at the top joining. And we come to cemented in place. We're just trying it in here now. Do you need to do rubber dam? No. Okay, now let's get this into perspective, sorry. Rubber dam is one way of isolating. Okay, you need to isolate so that you can cement without the risk of saliva. Sometimes we can do that very rapidly, very easily with just cotton wool rolls. Okay, sometimes we have to go to rubber dam. A situation like this, unless the patient's got high amounts of saliva, very comfortable just using cotton wool rolls. Canine to canine bridge, as we've gone and prepared, that's rubber dam. That's going to take an awful lot more. The teeth are further apart. To go and get both of them dry at the same time and put my Maryland bridge on and go through the etching procedures, much more complex. That's going to be rubber dam. So my bridge is now cemented in place. And there we can just see, again, probably just 0.5 millimeter short of the incisal edge. And that will last my patient their lifetime. We can also use Marylands in combinations, okay? So don't think that if you're going to do an adhesive bridge, that means both wings have to be adhesive. We can start to combine. And by combining, what we're talking about is using potentially a full crown on one and a Maryland on another. This is called a hybrid. And a situation may well be where there's a missing first premolar. And the canine is perfectly good, healthy tooth. And the 5, the second premolar, has already got a crown on, or maybe a large MOD amalgam. And we would then do a fixed movable bridge using the Maryland on the canine to minimize preparation and use a normal full crown preparation on the 5. However, if we're going to do that, and this is timeout, big time, big important part, this has to be a fixed movable design. Do not put a Maryland adhesive wing and a full crown into the same preparation, same bridge design, unless you have a fixed movable attachment, a stress breaker between them. And here's a couple of instances. So I've got a couple of cases to show you here. So we've got that case we're talking about, a crown on the 5. The 4 is missing, and we're going to put a Maryland wing on the 3. Okay, there's my tooth preparation. You can see it quite well here. Okay, so we've got distal groove, we've got mesial groove, we've got rest seats, 3 rest seats, and we've also got a lingual groove just there. Okay, and we're doing a full crown preparation. Different case, because this is now a molar, but the same sort of idea. We've got a metal wing, and you'll see a close-up in a few minutes. We have the fixed movable attachment. Our fixed movable attachment is essential in terms of the stress breaking effect, taking the stress off the cement lute of the Maryland. Okay, and here we are again, canine, mesial groove, distal groove, rest seat, finish line. Okay, standard crown preparation on the already crowned upper left thigh. And of course, we'll cement, this is fixed movable, so I'll cement the anterior retainer on first of all, and then I'll go and put the posterior on. Also really important that when you're doing the fixed movable, because the male and female are going to link together, you have to ensure that the anterior abutment, the canine this part, the Maryland, fits in exactly the right position. Otherwise, your fixed movable will not attach itself. Hence another reason for all these little tooth preparations. Okay, the bridge either fits in exactly the right position or it doesn't fit at all. And there's our close-up of my intra-enamel preparations. And there's the close-up of the impression showing you the sharpness that we've got from the Maryland preps. And again, another case showing you the fixed movable element just here. Okay, and there's the little fixed movable. So in terms of the metal wing, if we're going to do a fixed movable, then the female, the fixed movable, is off the back end of the metal wing. So it's an extra coronal attachment. And the male portion, which is always attached to the pontic, then slips up and down into the female. And of course, remember, we have to take something off the base of the male in order to allow that movement to go up and down. If we don't take anything off the base of the male, then under normal loading, it's acting as a fixed fix. It's not acting as a fixed movable. Okay, now let's look at a posterior one. And for the posterior one, we're going to choose a 4-5-6 bridge to do. And we're going to do Maryland wings on both the 4 and the 6. And we're going to do a fixed movable design. Now, again, important that we get the groove sorted out, we get the rest seat. So let's have a think now. My bridge is going to be attached here, the Pontic. Where can the Pontic displace? Okay, so I've got a tooth here. Where can that displace? Okay, first of all, it can displace apically. So I need something to stop it displacing apically. Okay, where else can it displace? Tooth can go from side to side, so it can displace to the buccal, it can displace to the palatal. Okay, so I need buccal and palatal resistance form. I need apical resistance form. Where am I going to get those things to or from? My buccal and lingual, buccal palatal displacement, I'll get from my groove. And again, one groove will stop both buccal displacement and palatal displacement. Okay, what about apical displacement? Where would I get that from? Most people would normally say, well, you're going to get that from rest seats on the occlusal surface. Now, I'm not a lover of rest seats on the occlusal surface for two reasons. Number one, it can interfere with the occlusion. And what we have to do then in certain situations is either prepare the upper tooth for the rest seat or prepare the lower tooth so we have space for the rest seat. And the second thing, of course, it creates more metal on the occlusal surfaces, and aesthetically it doesn't look as good, especially on the lower. Are there any other areas where we can stop apical displacement? And you should be thinking to yourself, yes, what about the base of my groove? As long as my groove has a definite base, so my groove's going in, my metal's going in there, and as long as I've got a definite base for my metal groove, then there's no way that that Pontic can slide down any further. So you can get your apical displacement resistance form from just the grooves themselves, making sure you've got a nice base. That means your groove just doesn't peter out to nothing. Your groove has got to have a 0.5 millimeter base to it, which is what we're going to do here. Okay, so first thing we need to do is mark up contact points. We need to be aware of where the patient's existing dentition and occlusal contacts are, because we're going to keep our metal framework below or away from occlusal contacts. So first thing, get some occlusal marking tape in there, tap up and down, find out where the occlusal contacts are. Now we have two options here. If you think the occlusal contact is going to go too close to where your metal wing will be designed to go, okay, so let's just look here, and let's say that I'm going to have my metal wing, and in order to get maximum resistance retention form, my metal wing needs to go from here, supragingival, up to as close to the occlusal contact as possible, okay? And let's just say that my occlusal contact is here. I will put my finish line 1 millimeter below it. So I don't want my metal framework to encroach too close to the actual contact, okay? And I want to keep it 1 millimeter away. So now what happens if my occlusal contact was down there for whatever reason? 1 millimeter down from that means that I'm not going to have much surface to play with. So either we reduce the height of the metal framework as it goes palatally, or number two, we do an occlusal adjustment to the upper tooth or to the lower tooth, and we take that contact and we move it a little bit higher towards the cusp tip. So we can do that, or we can change our framework, okay? Most of the time, I would like to modify the contact, and that's simple. You have a tap. If you have a big contact here, then take the lower part of the contact away. A little bit of enamelplasty. So that contact appears to go higher up, allows you to go closer to it. So modify the contact. Now we're going to put grooves in. Where are we going to put our grooves in? Okay, let's work out our grooves. First of all, we're going to, in this instance, we're going to go through the contact. We've already got space here, but we didn't, we'd still go through the contact. And looking from the front, we need to look from the front, and we need to start thinking, I want maximum metal wraparound as possible, much as possible, but it can't be visible. So I've got to look from the front of the mouth, big E, okay? Look from the front and see whereabouts you can no longer see the mesial aspect of that 4. Where you can no longer see it, as in it's hidden by the 3, then that is where we place our groove. So our groove is placed into a non-visible area. We don't want to see a metal line, okay? And now they're exactly the same on the distal, okay? We go and put our groove where we can't see it. So that might be with a Julia Roberts wide smile. It may be putting it here. Somebody with a smaller mouth, smaller smile, it may be that we can bring it round to here. Okay, but we have this maximum wraparound as possible, and the wings, the end point of the wing is delineated by your groove. So you tell your technician, that's the place to put your grooves. That is where the metal wing stops. And you can do that in the mouth. Okay, the best person to do that is you, looking when the patient gives you the big beaming smile. And here we're combining longevity, resistance form, maximum wraparound, but also aesthetics. Okay, so the same thing with the 6. So plan where your grooves are going to be. I'm going to have 1 mesial, 1 distal, I'm going to have 1 palatal. Okay, super gingival finish line. First of all, make sure again with our guide planes, look at our tooth initially. Okay, if we just go back to 1, look at the tooth. It comes out, okay, and it diverges as it goes out. It doesn't converge. For us to get a metal wing to wrap around, we need convergence. But our tooth is diverging, not converging. So we have to go and now prepare guide planes so that we get convergence. Okay, the further down you put your groove, the more you go into an undercut area, the more you have to go and do more tooth preparation to get your guide planes. But my guide planes need to have my 12-degree convergence angle, 6-degree axial inclination. Okay, and now we'll decide where we're going to put our groove. My distal groove is going to go here, down the long axis of the tooth again. Mesial groove, I'm cutting through mesially, making sure I've still got my 12 degrees convergence angle, and I'm going to finish with my groove just here, okay, where it's not going to be visible. You could decide to finish there, here, here, depending on the visibility. It's down to you. Same sort of guide planes on the 6, exactly the same thing. What was divergent now becomes convergent by preparing the mesial wall and the palatal. You can just start to see just around about there that there's my finish line coming. And I've produced a long, flat wall for my Maryland wing to go down. Find out where your groove is going to be. Your groove will naturally be a little bit more to the buccal than on the 4 because we don't see as much on the 6 as we do on the 4. So it would be a little bit more to the buccal. Now we're going to prepare our lingual groove, palatal groove. Remember, this needs to be bisecting the mesial and the distal wall. Okay, so like this, then your groove needs to be bisecting that so we can get seating. There's our palatal groove, finishing a millimeter away from where my contact is going to be. Okay, and we look now, we have mesial groove, we have palatal groove, we have distal groove. Okay, and between them, that will stop palatal displacement and also buccal displacement. And remember your grooves like here, there, you can see them quite well. We've got a base. That base is stopping apical displacement. So we don't have to have anything on the occlusal surface. Same thing on the palatal. We're slicing all the way through. Mesial groove, palatal groove, and a very strange angle. There's my distal groove. Now again, with the distal groove, If this is a 6, okay? If for whatever reason you could only see the mesial buckle, then you could bring that groove round to the mid buckle groove. If it's a 7, you can't see it at all. You do a complete wraparound. As we mentioned, this would be a ring, a 360 degree. And guys, I've done some of those. Those are never going to come off. You go and do a 360 degree ring preparation on a molar tooth, put it in, cement it in properly, adhesively. That is never, ever, ever coming off. The Marylands that come off do not have resistance form. You go from sticking on the platal aspect to 180 degrees with grooves, to 270 degrees with grooves, to 360 degrees with grooves. Okay, the resistance form starts to go through the roof. Your longevity starts to go through the roof. Understanding tooth preparation is the key to your longevity. Okay, we're coming to the end now. I'm going to talk about cementation and aesthetics. So cementation, 2 different types of cementation, metal-based and zirconia. Our metal-based traditional, okay? We have a metal wing. It is non-precious, okay? A non-precious metal wing, which is cast. That non-precious metal wing between 0.3 and 0.7. I prefer to get to 0.7. How do you get the space? Very often, how do you get the space? I don't like to particularly prepare much of my abutment tooth. I'll take maybe 0.1, 0.2 of a millimeter off just to get to the subsurface enamel, but then I'm going to take my 0.5 millimeter off the opposing tooth. I like to share the tooth preparation between both abutment and opposing tooth. So I'll gain my space there. Once you've gained your space, guys, also remember temporization is hugely important. That you need to put something on if you've adjusted the upper or the lower, because you're going to get over eruption occurring. So you need to go and temporize this as you would do a porcelain veneer. And for me, that's putting some flowable composite into the lingual or palatal surface. It's going to go into those grooves. It's going to go into the rest seats, and then going to have it come over the incisal edge, a nice flowable composite, very translucent, not going to be visible. And I want it to come around onto the buccal surface. So I've now created something that can't come off. I'm not etching it in place, I'm just physically putting it into areas where it can't come off. And that way I'm temporizing. So our traditional metal-based, non-precious metal, ideally 0.7 of a millimeter thick minimum. Sandblasted, okay, sandblasted with 50 microns plus. I like to use 120 microns of sandblast. So we get a nice thick sandblasted surface. Okay, we then clean that surface with phosphoric acid, and then we have that sandblasted surface onto the etched enamel tooth surface, and the intermediate is Panavia, a 4-meta agent. That's all we need. Any traditional 4-meta agent, I prefer Panavia, the original Panavia. Remember, Panavia comes in many different forms now. Go back to the original Panavia that bonds metal to tooth. Okay, has to have 4-meta in it. There are other materials available. So this has been done year in, year out. It's totally predictable as long as you're getting good isolation. Now, the more recent ones, the more difficult ones, comes with zirconia. And it's only just recently that we're able to start bonding zirconia pretty well. Now, what do we know about zirconia? Can we sandblast it? Well, yes, we can. And we're going to sandblast it with a different grit size. Now we're talking 30 to 50 micron. Zirconia comes in different forms. If you're using the translucent, which I wouldn't advise, then that's less amount. That's a smaller grit size. That's now 10 to 20 microns. But if we're using the standard zirconia, then it's a opaque material, nice and strong, okay, 30 to 50 microns aluminium oxide. We've then got to clean the surface of all the phosphates that are still on there, okay? And we do that with some form of cleaner, and we also put Visco Monoblond on top. So we want a primer. This is called the APC technique, okay? Remember that in your mind, APC. Air abrasion, number 1. Number 2, primer. Number 3, composites cementation. Okay, adhesive composite cementation. It's called the APC technique. And there's many on the market. The one I like to use is the Bisco Monobond Plus. Okay, you'll see this in the literature as MBP, Monobond Plus. And that is now added onto the sandblasted surface. Now, if zirconia gets contaminated in the mouth, we've got to be able to clean it. This is not cleaning it. So if we have a porcelain veneer and we try the porcelain veneer in the mouth, we can then go and clean it with phosphoric acid. We can't do that with zirconia. We can't clean the saliva off with phosphoric acid or with water. Okay, we have to do it with a special product. Again, that's because of the phosphates which are precipitated on top, and therefore we use something called IvoClean. The third stage in this process is an adhesive cement, an adhesive composite luting cement. Okay, and that for me is going to be RelyX. So I will etch the tooth first of all. And remember, with the etching process for the tooth, not just 30 seconds. Remember that etching can take an awful lot longer depending upon the amount of fluoride in the water that the patient's grown up with. And it can take up to 2.5 minutes for you to etch a surface. So etching we do in 30-second increments. Etch for 30 seconds, wash, dry and look. What we want is that pure white powdered sandblasted look everywhere, not just mottled. If it looks a bit mottled, then we'll go and sandblast, go and etch for another 30 seconds and then wash off and dry. We keep on doing that until we've got our ideal etch. Okay, we've now got our ideal etch. We've got my zirconia wing, which has been sandblasted, which has been primed, and now we'll use RelyX as our cement of choice. Okay, and that will give you better bonding. Some people are happy to use a resin modified GIC, but we want maximum bonding. For me, maximum bonding comes then with RelyX. There are other ways. Okay, so it's not just one technique. That's my preferred technique. There are other ways. Some technicians like to put a thin layer of ceramic on the fitting surface of the wing. So it increases the thickness by probably about 0.2, 0.3 of a millimeter. Okay, already our zirconia wings need to be 1 millimeter thick. Don't go less than that. And remember, zirconia is not going to be as strong as metal. Our connectors need to be longer, so you need space for your connectors. We need the same sorts of tooth preparation, but our tooth preparation now is no longer as sharp. These are rounded tooth preparation features. Okay, if you're taking it up to the incisor ledge, as in a upper cantilever where you've got a stress breaker, then you don't need as much preparation. You can get away with 0 preparation. Okay, but again, the same rules and regulations apply. Maxillaries, less prep than mandibulars. Posteriors, more prep than anteriors. Okay, longer span bridges, more prep than shorter span. Find out if you've got a stress breaker. Introduce the stress breaker, single cantilever or fixed movables. So the other technique I was talking about was having porcelain, ceramic, bonded onto the surface of zirconia, which we can do. Technicians have been doing this for many, many years, and that forms a really good bond. And then you etch the ceramic. So it's like putting on a porcelain veneer. Okay, so those are the 2 ways that we've got. Now let's go through and finish with an aesthetic case. And we're going to finish with a young lady. First of all, in terms of longevity, where are we with zirconia bridges? Now, we have good success rates now. We're getting up to 10-year studies. We've certainly got good 5 years, and those are progressing up to 10 years. So what does this tell us? An all-ceramic adhesive bridge, failure rate 11%, metal failure rate 4.6. So 2016, what does this say to us? It says to us roughly 88 to 90% success rate with zirconia, 95% success rate with metal. not too different. Okay. Now, one person doing multiple cases, okay, not quite the same as multiple studies, meta-analysis, where everybody's doing a little bit. This is one person doing it very well to his technique, which we've just described. Okay, follow-up of 15 all ceramics over 8 years, 100% success rate. Okay, but that's one gentleman. A meta-analysis, another one, showed an estimated 5-year success rate, 88% for metal-based, 84% for non-metal-based, for zirconia-based. So very, very similar, okay? Only difference is needs to be thicker, connector needs to be longer and bigger, and we have a different bonding situation. And again, a final study getting right up to date, 5-year success rates, 92%. So you should be looking at a 5-year moving up to 10-year success rate of that 85 to 90%-ish. Okay, and it's important from a consent point of view that you're saying this to your patient. Okay, in order to gain consent, we have to say to our patients, this is a success rate of this treatment, there's a success rate of that treatment, there's a success rate of this treatment. Okay, call it longevity if you want to, and the patient then decides themselves what they want doing based on those 3 parameters. Remember, maximum longevity we want, maximum aesthetics, minimum tooth preparation. And you have to choose which is the most important 2 out of all those. So here's our case that we're going to finish on today. We have a lady with 2 metal-based zirconia bridges. Sorry, metal-based, removable, resin-based Marylands. Okay, 2 metal-based Marylands. As you can see, the metal is even showing through, so it's showing through on the incisal edge. And these are a little bit opaque-ish, the actual pontics, the PFM pontics. And this is what we've got. This is post-ortho, and the patient is now not got enough space for implants, and so having their long-term bridges placed. Not happy with the overall appearance, wants to have a much nicer appearance, disappointed that she could not have implants, and the reason she couldn't have implants is at the end of the orthodontics, then the 2 root apices, central and canine, are like this. So it appears that we've got space here, but we don't have space at the apices. Yes, the first thing you're going to say to me, why don't you have more orthodontics? The orthodontist says he can't do any more. The patient's got tired of orthodontics. So end of story, no more orthodontics, no chance for implants. So we take the metal-based adhesive bridges off. And the first thing we're going to see is, again, the poor tissue contour. So we need to create, again, an ovate pontic. So I'm going to go to my burr again and do gingival rotary curettage. And from here, we've now gone to there. We've got, at the moment, if you put a Maryland bridge in place, either it sits here or it overlaps the gum. What I'm trying to do is get the pontic so it goes into the gum, hence the gingival rotary curettage. Okay, we've then added a little bit onto the O-pontics, remember, here. We've now pushed the gum back so you have a space. If we don't do anything, that gum will just regrow to its same position it was beforehand. So we have to take these off, obviously, to do the gingival rotary curettage. But what we have to do then is add composite onto the apical or the palatal surface of those Marylands so that we can push the tissue back, okay, and stop that tissue from coming forwards. So we've created our definitive shape. We then go and take our impressions, and here are our 2 zirconia wings, long connectors, 1 millimeter thick zirconia wings. And here we are now cemented in place. And you can see better aesthetics, nowhere near the same amount of grain. We've just got natural translucency at the edge, and we've got some zirconia, little bit of bleeding from the flossing just there, but that will get better. And we have a happy patient. So I'm hoping that you've enjoyed the presentation. This is our final slide of our patient before and after. And you can see the metal show through, the non-metal show through, metal show through, non-metal show through, pontics sitting on the ridge, and pontics hopefully coming out of the soft tissue. Hope you've enjoyed it. I hope this has given you some thought. My take-home messages are: understand, number one, understand bridge design. You cannot, should not do Maryland bridges unless you understand bridge design. Simple as that. Okay, that's my take-home message. Understand stress breaking, all part of bridge design. Understand occlusal forces, all part of bridge design. And if you can understand bridge design, then, as I said, the 4 ways that we design a bridge from front to back: choose your abutments, choose your design, and then finally choose your retainer. And there should be no difference when you're talking to a patient about a bridge. We have our option: removable partial denture, bridge work, implant. One of the many options for doing bridge work is an adhesive bridge, but it's just an option. The adhesive wing is a retainer. That's all it is. Okay, try and remember that. Okay, guys, thank you very much for your attention. I see we've had over 100 people listening in, and you can imagine we're going to have quite a few questions. So we've got 19 questions awaiting us. Please write them in if you wish them, and I'm going to click on those now, and we'll start to look at the questions that we've got. Andy, thank you for your lecture. Thank you, Andy, for your attention, and thanks for coming in. Explain the statement at the beginning of this lecture: we should consider the anterior space first when doing bridges. Okay, reason we do that is because if we're considering fixed movables, then the posterior bridge will fit into the anterior. So if we did a fixed bridge at the back of the mouth first, it may be that that would not fit into the anterior. So when we're doing like a canine 3 to 3, imagine we're doing a canine bridge 3 to 3, we're missing a premolar. One of the options would be, I'm not saying the only option, we have many options. One of the options would be a canine to canine bridge with a female attachment in the distal aspect of your canine. And then the posterior bridges fit in. So the anteriors always go in place first. The posteriors will go in secondly. We've cemented secondly. Okay, and so it's more important you work out the anterior design first, then the posterior. I hope that makes some sense. Amani, how do you cement old bridge work temporarily whilst waiting for new bridge? Simple for that, you will use now glass armor cement. So don't go back to the Panavia, use glass armor. That should last you, so sandblast, glass armor, dry surface, that should last you a month, 6 weeks before it starts to come off, especially if your design is a single cantilever. Shaza, okay, let's look at this. How do you typically choose the incisal extent of wing design? We go back to the original 3 points. What's most important? Is it going to be aesthetics, longevity, minimum prep? Okay. We know that if we don't want to have any shine through, then it's somewhere between 2 to 3 millimeters away from the incisal edge. As we creep up to the incisal edge, we get a little bit more bluing. Some people, and I'm not saying don't do this, some people, when it's absolutely imperative that we get the maximum height for bonding, but reduce it by the minimum amount so we get good aesthetics, is they'll do a try-in at the first stage. So do a try-in of the metal framework, and then if needs be, see if there's any show through, and then grind down, you yourself in the mouth, grind down the incisal extent of the metal wing until it gets to a situation where it's no longer visible. That goes back to the technician. He polishes, smooths, and resandblasts, and then starts to put his ceramic work on top. So we can do a metal try-in, and we can see the amount of graying that we're getting. In case using zirconia Emax, do you prefer TC or diamond burr? So if I'm doing preparation for my zirconia, then it's going to be a diamond burr. I do not want sharp line angles with zirconia. Zirconia doesn't do sharp line angles. Okay, metal can do sharp line angles and we'll get better retention. We're not going to get anywhere near the same retention and resistance form from zirconia as we will do from metal, hence more rounded. What's the gadget called? The Parallelopret. That's it. It comes from Dentsply. So Ahmed, if you want to go and get it, it's the Parallel. Okay, and then O. So it's parallel, inverted comma O, inverted comma prep. Parallel O prep. Alan, is it possible to use flowable composite or general composites for cementation as well? Yes, it is. Not as good. Okay, not as good. It is, of course. The studies would show you that a 4-meta will bond better to metal, so you get a physical and a chemical bond. If you're using composite, you're just going to get a physical bond to the metal framework. So yes, you can do it, but I prefer to use every little added extra that we can get. Okay, next question from Edgardo. Very interesting webinar. Okay, thank you. Denise, can I know how you manage patients who have existing Marylands but go on to develop periodontal problems, e.g. recession affecting aesthetics? This is a difficult one because Marylands are inherently there for single cantilevers. If you have recession and you have periodontal problems and you have mobility, it's more difficult, number one, to fit a lot of Maryland bridges, Maryland wings together. You have a greater chance of failure. You need to do more tooth preparation. The second part is that you and your technician have got to work out aesthetically whether a Maryland will work or not. Obviously, with a Maryland, it's a metal wing. You can't do anywhere near the same aesthetics in terms of blocking out black triangles, for instance. You can do that with a full crown preparation and a new retainer that's a full crown that goes into all different shapes and forms to try to push tissue around to try to reduce black triangles. You can't do anywhere near as much with a Maryland. So Marylands are there when we've got good tissue. Okay, you don't have good tissue, you're missing incidental papillae, you've got recession defects. It's a lot more difficult to work with them. Not saying impossible, a lot more difficult. Okay, next one. Maxi. Hi, I'm Maxi. Prior to doing the course, Marylands filled me with dread due to the lack of confidence that I had with regards to resistance retention form. Because of this, I hardly ever did them. I have since done quite a few. It took a couple of cases for me to become confident. Now I realize that they are a game changer. Significantly less tooth prep and less invasive than implants. I love them. And more importantly, so do my patients. Thank you, Maxi. Maxi, for those of you that don't know, Maxime Soden did our restorative aesthetic course over in Dubai, where we go into great detail about how to do these. And again, it's the same predictable results that we get. And I think that's the important part. Some of those scientific articles there said we can no longer consider the adhesive bridge as something that if it falls off, then we can forget about it. Okay, the adhesive bridge needs resistance retention form. It is just a more minimal, a greatly more minimal preparation. But if you put your resistance retention form in there and you understand what you're talking about, you understand the science, and here's a plug for the courses, guys, please, if you don't understand it, come on our courses and we will teach you the predictability, as Maxime says. And they become a game changer. They really do become a game changer for patients and yourself in terms of minimal preparation. Thanks, Maxi. Thank you for that. Okay, Amans Louis. Is it possible to cement adhesive bridges with Rely-X? Again, zirconia, yes. Okay, it's possible to cement them with lots of things. If you're asking me, do I cement zirconia bridges with Rely-X? Yes, I do. Do I cement metal-based adhesive bridges with Rely-X? No, I don't. Okay, it's possible to, but it's not what I like to do. I like to use Panavia. Why? Tried and trusted, been using it for 20 years, does not let me down. 4 meta agent. I get a chemical and physical bond. Praveen, great presentation, thank you. What's your advice for replacing 4 adhesive bridges, replacing all 4 first premolars in one patient? That's an interesting one. So I presume your first premolars are missing and you're now contemplating replacing them off the second premolar. In an interesting situation here, that if you make sure that your premolar pontics are out of contact, then as long as the 4 teeth are all opposing, the pontics are all opposing each other, then I'm happy to go with a single cantilever off the 5. The reason is, if the pontics are opposing each other, those pontics cannot over-erupt. If you are doing 1 premolar replacement, so upper premolar off the second premolar, but you had a tooth underneath it, and you left that premolar out of contact, the pontic out of contact, lower premolar would over-erupt. And so this is just general bridge design, nothing to do with Marylands to start off with, general bridge design. At the back of the mouth, the only cantilever bridge you can do with predictability, remember that big word again, you can do every single cantilever in the book, but what will give you predictability? The only one will give you predictability is a 5 off a 6, and that's Anti's law. And the reason is because of you want to take your pontic out of contact. Okay, why? Otherwise you're going to have great amounts of rotational stress. Okay, so you have a 4 off a 5. If that 4 is in contact with the lower 4, you're having a lot of off-axis loading, which is putting stress on the cement loop, putting stress on the tooth. That's not good. So keep it out of occlusion. However, lower tooth over-erupts. Remember with doll appliances, those of you that have caught my webinar on doll appliances, then they over-erupt more quickly as a younger patient, more slowly as an older patient. So I'm a lot more likely to push the boat out a little bit more for cantilevers in the older patient, knowing I'm not going to get anywhere near as much over-eruption. But I have to be aware of it, even with an older patient. If I do a cantilever, I'm always going back and reducing, looking at the occlusal contact between the pontic and the opposing tooth. And if needs be, just adjusting the opposing tooth, keeping it just out of contact. Now, if I've got 4 teeth opposing each other, no chance of over-eruption if these are 4 pontics. So I would, in those cases, just if, and it's a big if, as long as the pontics are all opposing each other. Okay, if the pontics are not opposing each other, then you have problems. And also it depends on the patient's age. For this to happen, I would imagine our patient's quite young. So we don't want opposing contacts on those pontics. So single cantilever will be fine. If you've got opposing contacts on those pontics, then you need to have an anterior rest seat. That anterior rest seat is usually then a Maryland wing, okay, with a fixed movable attachment in between. Sometimes, okay, and this is a big sometimes. Sometimes you can make that Maryland wing where, because the contour of it, it can just rest on the anterior abutment. In this instance, it would be a canine. Don't do a Maryland wing. You can just sometimes get it so it's over contoured and just rests on the canine. But your patient's then got to be taught to floss between the metal wing, that little spigot, if you like, and the canine to make sure that you don't get any caries. So really, really interesting question. Good luck with that one. Vishal, one of my patients is having missing upper right one, upper left one, is having metal ceramic crown. What's the best thing to do? Upper right one. My patient is having missing upper right one. Upper left is having a metal ceramic crown. Okay. I would just go and do a cantilever off the upper left one, really. So a PFM bridge. So it wouldn't be a Maryland or anything like that. So it just took me a second to realize that. Yes, just a single cantilever, upper right one off the upper left one. Make sure you have a light intercuspal holding contact on it. Make sure there's no guidance on it. By that, on it, I mean on the pontic. Andy, is the alkaline cleaning solution used as zirconia adhesive bridge cementation the primer, or is it a separate agent? It's a separate agent, Andy. You use the Iberclean first of all, and then you can go and do your primer. If it comes back from the lab, remember, we only need to do that if it's been tried in the mouth and you got saliva contamination. Otherwise, if it's not been tried in the mouth, okay, then you don't need to use the Ivoclean. But if you've got saliva on it, yes, you need to use the Ivoclean before the primer. Liz, for missing upper left 525, would you go for distal cantilever or always opt for mesial cantilevers are better? Mesial cantilevers because there's less force on them. So always, and the teeth, if you think about teeth always wanting to slide forwards, we have this thing called mesial drift. And therefore, teeth are wanting to move forwards. Teeth aren't wanting to move backwards. A distal cantilever makes the tooth rotate backwards. That's not what they want to do. So always mesial cantilevers possible. And that would be a simple one, the 5 off a 6, ideal. Is the surface area a major factor consider with which abutments to retain? Yes, they are. But you can increase surface area by doing the guide planes, the rest seats, the pin channels, the grooves. So yes, always. But remember, the surface area is there for retention. Okay. For post-ortho stability to prevent relapse, would you consider fixed? Don't like using these for relapse. I would rather go and use a, if possible, single cantilever to replace a missing tooth. And then to stop ortho relapse, 2 things. First of all, just metal wire, splint and composite. And then obviously an Essex retainer over the top. I don't like the idea of changing your resin bonded bridge design to maybe include an extra wing, just to make sure that that wing sticks on the adjacent tooth so the adjacent tooth doesn't move. That's asking for failure. So splint the teeth with composite and metal and have an Essex retainer to keep them in the right place. For missing teeth, go and do a cantilever bridge and keep the 2 separate. Okay, next one, Amani. How can I lengthen a short upper lateral pontic when opposed by a canine? Okay, simple, you manipulate the lower canine. I've got no problems in taking 1 millimeter off the lower canine, sometimes a little bit more. So it's either by, in extreme situations, opening up the vertical dimension. That's very extreme. Other situations, using a Dahl appliance to hammer down and intrude the lower canine. Another situation is, again, we've discussed it when we did Dahl appliance and treatment of the worn dentition. Occlusal adjustment, get the mandible to drop backwards. Another opportunity, grind down the canine. So you've got 4 options there to give you that little bit more space. Andy, after zirconia surface is cleaned, Ivoclean, does it need to be re-etched? Yes, it does. So clean with Ivoclean, re-etch, sandblast it and reprime it. Alan, how do I prevent incisal crossover forces decementing upper anterior pontics? Not an easy question, Alan, and one that obviously I can't see the instant that you've got it. This is obviously an occlusal problem, and generally with occlusal problems, crossover can be a problem. And crossover is a problem when people don't have enough incisal overlap. So your overbite isn't deep enough, your overjet's not big enough, and therefore we only have limited guidance. So if we have limited guidance, our lower canines might do this and then go somewhere else. General rule of crossover is make crossover smooth. So find out where your crossover tooth is. If your crossover tooth is on a pontic, then make sure as you're going into crossover, you go from, let's just take an example, it's canine guidance, it's then canine guidance and crossover tooth, and it's then crossover tooth. Okay, so it's a smooth. So if you imagine it is canine guidance first of all. Okay, so imagine I'm putting this now on a mirror, sliding with canine guidance. Then my pontic comes into place, and then my canine guidance goes out. It's a very smooth way that we transition crossover. One of the most difficult parts. Fatima, amazing presentation. Thank you. Can something similar be done with glass ceramics? No, not strong enough. Sorry, Fatima. I don't want to be using my Emax for Maryland restorations. At the moment, not strong enough. Sorry. Odinaka, okay, thank you. Please give the ginger rotary curettage done the same day as the impression is taken. It can be, yeah, by all means. Do it, get it to stop bleeding, take the impression. Okay, most important part then is put a pontic back or a partial denture that stops the healing process, because the healing process will naturally, the ridge will want to come back to its previous position. That's what the natural situation is. And so you've got to get the healing to go more towards the bone. So you want a little bit of bone recession, and then you want your connective tissue and your epithelium to heal over that new position of bone. Okay, so yes, they can be done that same day. All that will happen is your healing wants to envelop the pontic. So you'll heal towards the pontic. So yes, very easily. Andy, do I run any courses in Australia? I've been over there quite a few times, Andy, to do some courses. I don't, but guess what? If you wanted me to and you could get a few people together, I love Australia. I played cricket over there. I spent a year over there many, many years ago in Perth playing cricket for Scarborough. Cricket is my first love, dentistry is my second. So I love the place, love coming across. I was last there probably about 5 years ago, but been many times. And I'm happy if you can get a group together, invite me. I would love to come across and do them. So yes, up to you. I mean, how do you temporize prepared retained? I think I went through that, I mean, and that is like you do with the veneer. So it's flowable composite, no etchant, but the flowable composite, so it goes into those retention features, goes over the incisal edge, and it comes round onto the buccal surface. Okay, so it's going into undercut areas, going into areas where it cannot physically come out. It has to break to come out. And as long as you make sure that the occlusion, it's not the occlusion, the opposing tooth isn't biting on it, so you have to understand that part, then you should get a really good temporary situation. Odinaka again, okay, please sir, how easy was it to take out the old bridge for the, very difficult. Good thing about non-precious and Panavia, it sticks. And so what I had to do, it took me about an hour and a half, it was just basically drill the old metal wing away. There's no other way of doing it. If it's properly cemented, it won't come off. And if you try and hit it off, crack it off, it might break a tooth. So you just drill the old metal down. It takes time. You're going to go through lots of burrs. Next one, Hannah. Great webinar. Thank you. Thank you, Hannah. What Maryland design would you consider for the following? 37-year-old lady had 2 lower retained A's removed, wearing part acrylic. We now have space equivalent to lower central and half. Okay, right. She wants 2 smaller teeth and 1 larger. Would you consider doing a single cantilever in this instance? Interesting one. You know, I'm 50% one way or the other. Single cantilever, less tooth preparation. Fixed, more tooth preparation. I honestly, without seeing the case, I cannot tell you. I'm sorry, and I don't like to sit on the fence. I like to try to give definite answers, but I'm sitting on the fence there. It would be probably a gut feel. Longevity-wise, single cantilever periodontal ligament. How long is the root of that one lateral incisor? If it's a good long root, and you can organize the occlusal scheme, so we've got a light contact on the lateral incisor, no guidance on the missing 2 centrals, then go with a single cantilever. If it's going to be difficult for you not to have guidance on the 2 centrals, or if the upper was a bridge, for instance, whereby you could keep the 2 centrals out of contact, then more likely to go with a single cantilever. If the upper teeth are natural teeth, and it's difficult for you to organize the occlusal scheme to keep those 2 centrals out of contact, then you're going to have to go with a fixed. So difficult situation. I can only give you some guidelines there. Amanda, Thank you for answering my previous question. Brilliant webinar. What do you think of designing a cantilever bridge off a lower left 7 replacing lower left 6? I don't like it. I'm not saying it won't work, Amanda or Mans. All I'm saying is that from a longevity point of view, it's not a predictable long span bridge. Okay, so you've said that lower left 5 is root filled. Is lower left 5 also crowned? Because what you can do then is replace the 6 off the 7 with a traditional Maryland wing, but then just put a little recess into the distal aspect of the 5 crown, and then you've got a little rest seat. So you're not going to cement it at all, but that rest seat stops rotational stress of the pontic. So you can get around this if you go and put a crown onlay, something like that on the 5, the root fill 5, and then have a rest seat, only a small, not a full rest seat, only a small rest seat that stops the rotation. Vishali, hi, do you take the impression for final Maryland bridge straight away after doing? I can do, yes, I can do. I've got no problems doing that. If you have got a highlight line and aesthetics is really hugely important, wait, get healing. But if you want to do it straight away, do it straight away. Yeah, I've got no problems. Hannah, regingival contouring. How long do you leave the soft tissue healing before returning to your preps and imps? I've just mentioned that, Hannah. I can do it sometimes if aesthetics is, I won't say secondary, because aesthetics is always there. But you know, some people are very finicky about it. So if people just want decent aesthetics, do it then. Don't wait, okay? If people want maximum aesthetics, highlights, and the reason I say you don't need to wait is once you've done the prep, the soft tissue will want to heal back to its normal position. So do your prep and you put a pontic in place. The soft tissue wants to come back to it. So you're always going to get a good envelopment around that pontic. You're not going to get recession. Okay, you're going to get good envelopment because the ridge wants to come back. So that's why I say you can if you want to. Nicola, missing upper laterals. Okay, single canine or centrals. I would say probably the usual one is canine because you've got more bonding, you've got a bigger tooth. However, does the patient have canine guidance? Will you be interrupting canine guidance? And if you are, think about putting it onto your centrals with a little bit more tooth prep. Is your canine guidance not very good? And actually putting a metal wing on there will improve your canine guidance. So I've got no real definitive answer, one or the other. One's just better for bonding. If you can improve the guidance by putting it onto a central or a canine, because the central's out of contact or something like that, then do it on that and improve guidance. If it's going to make your guidance worse, then do it on the tooth that doesn't make your guidance worse. If that's some. Also, aesthetically, central incisors, more chance of graying. Canines, yes, they'll be grayed, but the further back in the mouth you go, the aesthetics doesn't worry you quite as much. So from an aesthetic point of view, towards canines. Mina, thank you, Prof, for a wonderful lecture. I'm glad you enjoyed it, Mina. For a young patient missing lateral incisors congenitally, space being created using ortho for replacement, does it have to be 2 adhesive ridges to replace the gaps, or can it be a simple single unit zirconia adhesive ridge with both central incisors as abutments? I would not want to use both central incisors. Mina, again, what we said earlier about, not me, but the science about splinted retainers give more chance of failure. You have a greater chance of failure with those splinted retainers. So for me, keep them unsplinted, single cantilevers each time. Okay, so next one. We've got 37 in total. Goodness gracious me. Mustafa, Thanks for the amazing webinars. My pleasure, Mustafa. I hope you've enjoyed them all. Hard work, it is. You'll be surprised. It is quite hard work doing a webinar. In case you're missing central and another unrestored central, implant can't be placed. Medium diastema. Ooh. Can we use a labial veneer retainer to do a mini smile design, and what material? Okay. Difficult situation. I'm not so sure that I'd like to do a labial. I've seen them done. I'm not aware of any long-term studies on them, multiple studies as opposed to case reports. So I wouldn't like to do that. In situations like that in the past, we've gone and done the old traditional spring cantilever. So don't forget that. That worked very well. And by that we're looking and saying, okay, we've got maybe a 4, a canine, a 5, even a 6 from time to time that has or needs a crown. And you put the crown on and it has a, what would you call it? Like a partial denture. It has an area like a retainer which goes all the way onto the palate and then up to where the missing tooth is. Have a look on internet, spring cantilever bridges. I've never ever done one. I've replaced several and re-cemented them, and they've been very successful for the patient. I think I'd try that rather than going and doing a veneer as a cantilever. Otherwise, bite the bullet, and sometimes you just have to go and say, for longevity, I need to do a full crown prep. And you go and do a full crown preparation on the central incisor and do a standard zirconia cantilever bridge. Claudia, another excellent webinar. Thank you. My pleasure, Claudia. I'm glad you enjoyed it. Hannah, thanks so much. Appreciate hard without seeing patients. Okay, Aswina, if we could cut old bridge out, how do we make temporary cantilever bridge? Yeah, well, we can't. So if you have to cut it all out, then you have to go and replace it with either a new temporary resin bonded bridge or a partial denture. And that's one of the problems of it. If you can cut it off and reuse it, then you can do. If not, go to a new temporary bridge, which you can put on with glass ionomer cement, or in situations like that, just go to a partial denture. Simplest thing in the world, go to a partial denture. Mina, any books you suggest to reinforce the different types of bridge treatment planning? Not really, Mina. I would say, Mina, what you need to do is get my series of articles available on the internet. Just go on the internet and type in bridge design, and you'll be able to download the sort of 10, 12, 15 articles. Read all those. Okay, that becomes a mini textbook. If we wanted to bind them all together, there's your textbook. And after that, come on my lectures, and we can do it all together. Okay, guys, 37 questions answered, 2 hours and 5 minutes. It's time to go home and get the rest of the day on. I hope you enjoyed it. Thank you very much indeed for watching. I am back on Friday, and I am discussing stable-based dentures as a concept. Okay, bye for now.